Sorry guys, can you hear me? Apologies. Okay, that old white YouTube streaming stopped. So just listen to me from now, right? So now let's say we are talking about the line of demarcation. Line of demarcation is a very good finding in gross specimen to say, hi, it's wet gangrene, hi, it's dry gangrene, right? So let's say there's a toe. Assume that the gray toe is black in color, it's demarcated, it's destroyed, it's gangrenous, right? Now, in a gangrenous person, if it's a dry gangrene, you can actually see not exactly like a line, this is normal color. I'm just assuming that let's draw a pink color for normal, right? So this part here, it's completely normal. It's pinkish in color, okay? And the gangrenous part is black in color. You can see a perfect line of demarcation, right? That's what it means. There will be a perfect line between the normal and the gangrenous part. It's well defined in another way, right? It's very well defined. Because there's no superadded infection and this is normal, it is dead. That's how it will look like in a dry gangrene in gross. Not just for foot, even in intestine, you can exactly say, this part is dead, this part is live. But in a wet gangrene, there'll be no perfect line of demarcation because let's assume the same toe example, right? And this toe is black in color. What happens is because of the bacteria overgrowing, the bacteria will kind of come here as well. Will kind of come here as well. Will kind of come here as well. So it'll be like black in between, then normal. So it will not be a perfect line of demarcation. It will be very irregular because the bacteria tend to grow even to the normal tissue because they are more virulent. They are tissue eating, tissue destroying. That's all, right? Here there will be no perfect line of demarcation. Plus, grossly you will have the pus or the wetness, right? It's wet, so there will be oozing. In a live patient, there'll be oozing of plasma, oozing of tissue, whatever it is, you can see that, right? But in a specimen, you will not be able to appreciate that much because everything has been gone, everything has been wiped, it's been stored for years together, right? A perfect line of demarcation, dry gangrene, no perfect line of demarcation, plus oozing or wetness in the live patient is a evidence of wet gangrene, right? So just to sum it up, gangrene is necrosis, but gangrene is a clinico-pathological term, not a microscopic term. Gangrene is something I will write in a case sheet when I look at a patient having a black color foot, right? Which can be with or without superadded infection, most likely due to ischemia, mostly in peripheral extremities, and can also happen in internal organs. Dry and wet both have similar overlapping findings, but if it's fast, I'll generally go for wet. If it's slow, it generally goes for dry. Dry will have coagulative. Wet will always have superadded infection. Since there's superadded infection, there are lots and lots of enzymes which also causes liquefactor necrosis, right? And your line of demarcation is there in both. In one, it's there. In other one, it's not that great, fine? Okay. That's one thing which we have not covered clearly in detail, so we have covered that as well, right? Now, let's go to the next guy. Short note on reperfusion injury. How many of you exam had this? How many of you exam had a short note on reperfusion injury? Because see, we will read about reperfusion injury. Generally, I used to teach reperfusion injury when we come to CVS because it makes much more sense there for us to understand. Since your exam has reperfusion injury, even I saw a question which was shared by one of the students which had a question on reperfusion injury, right? We'll talk about reperfusion injury, which is very important for us, right? Now, we have to understand what does reperfusion means so that it's very easy for us to understand what is reperfusion injury, right? First, what is reperfusion? Okay, now tell me, if a patient has a myocardial infarction, MI, what will be the best treatment? MI reason is ischemia or infarction, right? So the best treatment will be give the blood supply back. Remove the clot, give the blood supply back. You will read drugs called as in thrombolytic agent, streptokinase, or I have a stenting. You must have heard about stent, right? You do a percutaneous coronary angiograph, remove the clot and put a stent. That's what we primarily do in reperfusion, right? Reperfusion is nothing but it's giving the blood back to a already dying or a dead tissue during infarction, right? Reperfusion is nothing but it's the regaining of blood supply to an infarcted or an ischemic organ, mostly to an infarcted tissue or an organ. Fine, that's what reperfusion is. Theoretically, on paper, it looks perfect, superb. It has to be good, right? It cannot be bad. How it should be bad? It has to be good because the tissue had ischemia. I'm giving blood back. It has to survive and come back and live normally. But what we saw was practically when we gave reperfusion, as a modality of treatment, people died faster than without giving reperfusion, or myocardium dead more than without giving reperfusion. Why is the question, right? So what is reperfusion injury? Is simple. It's nothing but because of reperfusion, there is more damage, and that is reperfusion injury. Okay, why is this happening? Why is this injury happening is the question, right? So first thing, let's say there's a cardiac tissue, fine, to which there is no blood supply, fine, and this is the normal cardiac tissue surrounding that with a normal blood supply, and let's say there's the blood vessel going to it, and there's a clot here which caused the infarct, fine. And what I'm saying is I will remove this clot and I'll introduce fresh blood here, hoping that the dying tissue will definitely regain its power back. That's the concept of reperfusion, right? Now tell me, if the shaded ones, which is a dying or dead tissue, right, this tissue which is dying or completely dead, right, can I say this tissue will have less proteins, less normal proteins, or more normal proteins? What do you guys think? Obviously less normal proteins, right? In other words, this tissue, can I say, will have less antioxidants? Yes, for sure. Your superoxide dismutase, your catalase, your glutathione peroxidase, everything will be less because the tissue is dead. All of them will be removed because it's a coagulative necrosis. The main mechanism of destruction is protein denaturation. I'll destroy every protein and it will be less. Fine. It's important, Hansraj. It's not for the FMGE. It's important for the doctor which you're going to become after clearing FMGE and NEET PG. Fine. Okay. So that's first problem. Now what happens is the fresh blood, whatever we are introducing as a part of the therapy, will have new reactive oxygen species. This reactive oxygen species is going to a tissue with less antioxidants. And obviously it's going to cause more damage. Right, you know that how a reactive oxygen species can damage, like Crazy Lucy said, it's oxidative damage. Why is the question? Because the tissue which is dying will have less antioxidants. To that I am pumping fresh blood, which will cause more damage. That's the first cause, right? If I have to write for a short note, I need to have a couple of more causes as well, right? Now, second, I'm introducing fresh blood. Can I say fresh blood means there'll be a little bit more calcium, more extracellular ions coming inside? Yes, no, maybe? Obviously, right? So the fresh blood, whichever is being given as a part of reperfusion injury, will have more calcium. This more calcium is coming to a dying tissue. What will calcium do in necrosis? Will it activate enzymes? It will. More of destruction, more of damage, right? So calcium itself can accelerate cell death. Accelerate the mechanism of cell death. If you remember the entire necrosis, calcium was an important component. More increase in intracellular calcium causes more rapid death and damage, right? That's also is going to accelerate the problem, right? That's second. Third, the most common causes by default oxidative damage, reactive oxygen species. We already know that first, right? Third problem, I'm introducing fresh blood. Can I say fresh blood may there'll be new WBC coming? Yes. And in this dying tissue already have DAMPs, damage associated molecular patterns. Will that activate the WBC? It will. The WBC is activated. Will they also contribute to reactive oxygen species? More death? Obviously, right? So in the fresh blood, there will be new fresh WBC, which will be activated when it comes to the area because of the DAMPs. We read about DAMPs and PAMPs in the sepsis chapter, right? Damage associated molecular patterns. This will cause more and more and more reactive oxygen species, which ultimately it's going to kill the person. Now the question is simple. So if I am telling if reperfusion kills the person, so does it mean that I should not treat a patient with heart attack? Should I not do stenting? We do left and right stenting, right? We give streptokinase. When you go as an intern, you will give streptokinase, you will give alteplase, you will give tenecteplase. You will give those drugs to save the patient. Then what is this problem? How I am going to circumvent this problem? It's a problem which has to have a solution, right? And what's the solution for it? The solution, this also has to be written if it's a short note. If it's a 3-mark question, just write what is the reason, that's more than enough. Solution is very simple. The time. There's something called as a critical time. Okay, this critical time is separate for myocardial infarction, it's separate for CNS stroke, right? It's separate. When you have an ischemia in the brain, I'll have, I think, 4.5 hours is the critical time. When you go to medicine, Dr. Santosh Sir will tell the exact advanced and the latest critical time. This critical time is very, very important. If reperfused within the critical time, okay, let's say the CNS critical time is, let's say, 4.5 hours. If I reperfuse within 2 hours, they came within 2 hours, right? Knowledge bar, come back after 2 years, we'll read pathology. What happens is, then you will have more use than damage. Which means, yes, here also I'll have reactotoxin species induced damage, but here it'll be more useful in means which I'll be able to salvage the dying tissue. I'll be able to salvage the dying tissue more than damaging the dying tissue. That's why the critical time is important. The moment you reperfuse beyond the critical time, okay, if I reperfuse beyond the critical time, here my risk is more than the benefit I get. Here, damage is more than the benefit. That's why we say, please don't go and reperfuse even if the person has reached the best hospital in the world. I'm not going to reperfuse a stroke beyond 4.5 hours. If I do that, I'm going to kill the patient more faster than it will automatically die, right? That's what about reperfusion injury. Reperfusion injury is nothing but an injury which is due to regaining of the blood supply to an infarcted or an ischemic area. The reason is simple. If I'm going to regain the blood supply via pharmacological or via surgical methods, it's going to cause new reactotoxin species, new calcium, and new WBC. All of them is going to damage the tissue more. So what's the solution to this? Should I stop reperfusing? No, I will still reperfuse. I'll still reperfuse with a very guarded approach. I'll be reperfusing within the critical time. If I reperfuse within the critical time, I'll definitely have more good things happening than bad. If I reperfuse beyond the critical time, is more bad, more risk. The risk-benefit ratio primarily tilts that side, right? That's why reperfusion is an important thing. And I'm sure when you go to your medicine, Dr. Santosh Sir will talk much about this. Fine. Okay. Now, just few short notes. I feel that if in first chapter, I would want the basic things of metaplasia. Necrosis apoptosis, I'm sure you'll be 100% in your fingertips. We'll still look at necrosis in the last. Metaplasia, calcification are these two short notes which I will ask if I'm an examiner, right? So I'm just going to talk quickly about metaplasia. You guys already know about metaplasia, so quickly revise with me. Metaplasia is a reversible process where one mature differentiated adult cell type, epithelium or mesenchyme, whatever it may be, is becoming another mature adult differentiated cell type. It's not becoming immature. One mature epithelium becomes another mature epithelium. That is what metaplasia is. And mechanism, we already read about it. It's reprogramming of stem cell, which is the primary mechanism. Sometimes, rarely, the adjacent cells also can come into the place. I don't want to try the rare possibility. Write the first and the most important one enough for me, right? Then directly go to examples, right? Squamous metaplasia is crazy loser. I think I covered amyloidosis in the immunology chapter, right? It's there in 6th chapter. We did cover that. When you come to immunology, I'll cover for sure. Right? Squamous metaplasia is the most common subtype of metaplasia. The reason for squamous metaplasia is smoking. Whenever you write any metaplasia, few things should be sorted. The stimulus, what is causing them? Then it's change, right? So I want native tissue. And what's the changed or the new tissue? Fine. And also the site. Squamous metaplasia happens in the respiratory mucosa or respiratory lining, where because of smoking, the native, what's a native tissue? Pseudostratified, ciliated columnar epithelium, right? Pseudostratified ciliated columnar epithelium becomes squamous epithelium. That's squamous metaplasia, right? Simple. These are few things required. The stimulus, the tissue where it's happening, what's the native tissue, and what's the new tissue it's becoming. So we call it squamous metaplasia, that's all. And the naming is also based on the new tissue what it becomes, right? Simple. The same way we'll go to columnar metaplasia, right? Stimulus is long-standing GRD. See, when you write in a theory exam, you need not write the exact pathogens of what happens. That's for us to understand when we learned, right? Here, things required. Stimulus required, location. What's the location? What will be the right location? Esophagus or lower end of esophagus? Examiner has maximum 5-10 seconds to read your exam paper. The way you are trying to gather the attention of an fellow Instagram follower via reels, the same thing I should have this as well, right? I need to give the important salient points so that it can grab the attention. It's not just esophagus, it's lower end of esophagus. It will not happen throughout the esophagus. Very, very unlikely. It's a lower end of esophagus, right? So the chronic GRD, chronic untreated long-standing GRD will have more acid, which is the stimulus, right? This acid will go to the esophagus where the native epithelium of the esophagus, which is my squamous epithelium, is going to slowly become your columnar epithelium. I want this word to be there by default with goblet cells. Without goblet cells, I'm not going to be comfortable to call it a metaplasia here. So I can call it a Barrett's esophagus, columnar metaplasia, goblet cell metaplasia, glandular metaplasia, whatever name you want, we can call it, right? It's Barrett's esophagus, that's all, right? So if I know it's Barrett's esophagus, please, since it's an important topic in metaplasia, if possible, if time permits, add 2 more points. The gross finding of the red velvety mucosa, again, if time permits, write this, and the microscopy, you can see the goblet cells, and to identify goblet cells, I need a stain, which can be Alcian blue or PAS positive. If required, these are mucin stains, which will be positive if required to identify. Otherwise, ignore it, right? They should be, since it's a question of metaplasia, there should be more than enough. These images are important when we read about Barrett's esophagus in the esophagus chapter. But here, for an exam purpose, it's not required, right? Because for 5 mark, I know the definition. I gave 1 mark for the mechanism of action. 3-4 examples. Squamous 1, columnar 1 mesenchymal. Not everything should be epithelial, right? I have osseous metaplasia, which is an example of mesenchymal metaplasia. Right? Here the stimulus is wound or trauma is a stimulus here. Trauma causing the growth factors to move away. The growth factors which form bone. It should be trauma to the bone, not to the soft tissue. Which will go from the bone to the muscle. And they produce muscle in bone. That's the osseous metaplasia, bone in the muscle, right? It produces bone in the muscle or soft tissue. Okay, that makes it osseous metaplasia, right? This is a reversible condition. This might not result in cancer, but sometimes most of the metaplasia has a risk of cancer, right? Then vitamin A is something which is very, very unique, where excess or deficiency of vitamin A, both of them can cause metaplasia. Do remember them, do mention them. If you want extra brownie points, extra marks, aiming for an topper or an university rank, write about bite hot spots. Bite hot spots which is seen in deficiency of vitamin A is actually a keratinizing metaplasia. Fine. Okay. Perfect, Tracy Loser. Factic myositis ossificans is this, osseous metaplasia. The other name of myositis ossificans is osseous metaplasia. It's not different at all. It's the same. Okay, it's a different term. Fine, which I've used. So long-term risk. It has to end up with a risk. Long-term risk of almost every metaplasia, like we had in the reasoning question, it's a double-edged sword. Because of metaplasia, long-standing nature, and since the stem cells are involved, there's always an increase in risk of carcinoma. Again, not in everything. Myositis ossificans might not have a carcinoma. Bite hot spots might not have a carcinoma. But GRD will definitely have a carcinoma. This smoking will definitely have a carcinoma. The reason is also simple. Bite hot spots is not going to stay forever as bite hot spots, right? Sometime, even without seeing a doctor, they might eat food which is rich in vitamin A. It's not going to be zero vitamin A. So it's a reversible condition. Comes back, goes again, comes back, goes again. But a long-standing untreated GRD and chronic smoker will definitely end up in having a cancer formation. Fine. Okay. Now, second question which I said I would want if I'm examiner to ask is what calcification. Calcification, I feel, is something which is important for you to know and important for you to understand. Fine. So calcification is a topic which has lots and lots of correlation when you go to systemic pathology and hematology. There are 2 types of calcification. Dystrophic calcification, metastatic calcification, right? Dystrophic, this is abnormal tissue. If you just write this, this will grab the attention of the person. Metastatic is altered homeostasis of calcium. See, this will easily grab the attention of the examiner. It's altered homeostasis of the calcium and it's an abnormal tissue, right? Dead or living tissue, dead tissue, degenerated tissue, I have dystrophic. Living tissue, abnormal calcium metabolism, you'll have metastatic calcification, right? So the table, dystrophic and metastatic, calcium level in dystrophic will be normal, serum calcium level. Here it will be elevated. The primary problem is alteration in the homeostasis, right? Hemostasis, right? Homeostasis. Fine. Etiology here, dead degenerative tissue will be the problem here because of repetitive damage, and the most common ion in any cell injury, any cell damage pathologically is going to be calcium. It accumulates. That's all. That's a basic principle of everything here. Dead and degenerative tissue will have definitely tissue injury. So tissue injury over the period of time will result in more calcium accumulation. When more calcium accumulates over the period of time, it will result in calcification. That's the simplest pathogenesis of dystrophic calcification. Metastatic, there's more serum calcium ion. That's enough. No, this is enough. It can deposit and cause calcification. So what could be the etiology of metastatic? In other words, what all can cause more serum calcium levels? Simple, your PTH, hyperparathyroidism, one of the important causes. Never forget, right? Second, anything else? Hyperparathyroidism is something which you never ever forgot. And any disease which will have rapid bone resorption, right? That's also important. It should be rapid. Slow and steady is not a concern here. Rapid bone resorption. So for rapid bone resorption, what we have is, you have myeloma, multiple myeloma, bony metastasis. Again, have rapid bone resorption. That will be a concern, right? Then chronic renal failure. Okay, chronic renal failure, there's a problem with the excretion of the potassium and the calcium and the potassium, which results in hyperparathyroidism secondary, which also results in more elevated calcium levels, which causes the deposition, right? Perfect, right? Then rarely we have few conditions causing like a milk alkali syndrome. These are again just extra brownie points, but doesn't really matter. If you write the first three, I'll be more than happy. Any pathologist will be more than happy because that will constitute the 90-95% of the cases. Right? Otherwise, milk alkali syndrome, Page's disease, which also is a rapid bone turnover, right? All of them also can have. Vitamin D toxicity can also have very high calcium levels, right? That's what happens here, right? So characteristic features here, you will primarily end up in having psammoma bodies. Psammoma is one of the important characteristic feature of dystrophic calcification. Psammoma is nothing but, psammoma means sand-like or gritty structures. And psammoma is nothing but a whirl of calcification, which is seen in the microscopy. That's very, very classical, which is primarily seen in tumors. Here, the most important thing is the most common structure where it's getting deposited is lungs, right? You can also see in kidney, renal stones, renal calcification is possible. Calcium also will be seen in the abdomen, which causes idiopathic abdomen pain, because when there's a calcification in the abdomen or in the GIT, when there's peristalsis, it will definitely result in the pain, right? So GIT, especially you'll have salts of calcium depositing in the GIT, fine? And also calcium being a neurotransmitter can cause neuropsychiatric disturbances. So it's a systemic disease because the problem is elevated serum calcium. The calcium level is more in the blood. If it's more in the blood, it can have a problem in the kidney, in the lung, in the brain, in the GIT, anywhere because of systemic problem. But here it's a degenerated or the dead tissue. The tissue will have the problem, right? Not throughout the body, right? So some of my bodies, where all do you see? It's very, very classical. At least don't forget papillary carcinoma thyroid. That's something which is very basic for me, right? You will see them in cancers. If you want to write theoretically, more pointers, right? Papillary carcinoma thyroid, papillary carcinoma of breast, papillary carcinoma of kidney, everything. Or write tumors with papillae. Okay. Serous tumors. That's again a tumor which will have papillae. Leiomyoma and meningioma. Okay. As an examiner, for basics for me to pass, I'll expect meningioma to be there and at least one tumor, papillary carcinoma thyroid. You just want to pass MBBS, then use papillary carcinoma thyroid and use meningioma. That should be enough. That's a bare minimum. Rest everything, I'm sure if you remember this, rest everything, I'm sure you'll remember that, right? Okay. So microscopy mein, how will you see calcium? Calcium is generally a bit of a basophilic structure. Bit basophilic, and automatically calcium has stains. There are two stains for calcium, which goes by the name KAL, right? A mnemonic which is famous throughout every pathologist in the world, which is 1 COSA, K for COSA. It's the most commonly done stain, and AL for alizarin red. That's a expensive stain, but it's a very, very specific stain which is being used, right? So that's a short note on calcification, right? So we saw two short notes, gangrene and calcification. We saw a little bit in detail about few things which metaplasia also we saw. We also saw few of the reasoning questions. I want to go to few long answer questions. See, there's something which I want an undergraduate to develop from now. When you have a theory question, long answer question given, most of the time the first question will be, what is the diagnosis? Generally, what will you do? We'll jump and write myocardial infarction. We never approach it the right way. It might be the right answer, but the way of presentation is going to grab you more marks and have less errors. That's what we are going to innately develop. In every one-shot series, I'll have scenario-based questions there. I'll tell you how to present the scenario-based question and also come to right diagnosis. Diagnosis is not difficult at all here. Can anyone tell the diagnosis here? Diagnosis is not difficult. Diagnosis is pretty simple. But this is a testing ground for you to develop the right approach. When you go to intern, post-intern as a doctor, the approach helps, not the diagnosis, right? Can anyone tell me the diagnosis? What do you think the right answer is? I'll read it with you if required. 55-year-old with a 12-year history of systemic hypertension, presents with exertional dyspnea, echo shows concentric thickening of the left ventricle, preserved chambers, discuss the cellular adaptation in this patient and explain the underlying mechanism. Anyone? Answer? Come on. You guys know it. You guys just have to comment. Crazy loser event with L hypertrophy. I think it's hypertrophy or left ventricular hypertrophy. Both are fine. It's a classical example of hypertrophy, right? Cardiac hypertrophy. It's very simple for me. Cardiac hypertrophy is the right answer. Pathological hypertrophy also is the right answer. Left ventricular hypertrophy, ventricular hypertrophy, everything is the right answer, right? It's not difficult for me to answer this, right? But what is required is, how do I present it? See, the way of presentation tells to a teacher, this student has thought through it and answered, nor just random guess or looking at the next paper, right? So here it's simple. First thing, I have a history of systemic hypertension for 12 years. That's good amount of time, right? So I have a risk factor here. Risk factors, systemic hypertension for 12 years. Write the duration if it's relevant, because long standing, it'll cause problem. 6 months hypertensive might not cause a cardiac hypertrophy significant enough, right? So duration is required here, write it, otherwise ignore it. Age might not be required here. If I have a hypertensive at 25 also, heart will respond the same. That's why I'm ignoring the age here, right? I don't mind about the age here, right? Presence with dyspnea, write it here. Might be required. Sometimes might be an overkill also, but we'll come to that very soon, right? So now the next finding is, next evidence or next clue you can write is echo. In echo, it is said that there's a thickening. Concentric doesn't matter for me. Concentric is just the appearance. If it's concentric thinning, answer will be different. Concentric thickening is important. So highlight on the keywords which required for me, right? There is thickening. So it's a thickening of the left ventricular wall. Preserved chamber size is fine, right? What's happening here is there is more wall thickness, which indicates there is increase in the size of the wall, which indicates I'm talking about an hypertrophy. If you want to add a little bit more, this is more than enough. I don't expect more than this. But if you want to add a little bit more, dyspnea is a characteristic finding. Can anyone tell me when will dyspnea happen in hypertensives? When the cardiac output is compromised or when the cardiac output is normal? Only when the cardiac output is reduced, right? So this dyspnea, you can add and say probably there is an reduction in the cardiac output. Again, this is not asked for, not called for, ignore it. It's a Viva, maybe I can answer it, but in an exam sheet, this half is more than enough for me. I have a risk factor, I have a clue, so it's an increase in size of the ventricle, so most likely it's hypertrophy, right? It's most likely hypertrophy, fine. So now, when I have hypertrophy, you're going to tell me that cellular mechanism. Mechanism of hypertrophy is simple. You have more growth factors. You can have increase in the mRNA content, which will increase the protein content. Once the protein content is increased, the size increases, so the organ size also increases. Sometimes you'll have better beta subunit of myosin fibers, which will be more effective as well. That's what happens in cardiac hypertrophy simply, fine. Okay, next question. Let's see if you guys can answer. Answer this as a internal assessment 1, not first chapter ka answer, right? Just answer whatever comes to your mind. What's the answer? Let's read. 28-year-old person, low-grade fever, evening rise of temperature, weight loss, chronic cough for 3 months. X-ray shows bilateral upper lobe cavity lesions. What's the most probable diagnosis? What you see in microscopy? Hardik, we are living in a country which is 140 crores people, right? In which I can say majority of them are young, active youths. There is going to be crowding in each and every sector what you go through. Crowd is not the problem. Be the diamond in the crowd, everyone will look into you. That's it. Fine. It's simple. Great. So the most probable diagnosis is TB. In microscopy, what I will see is granulomatous lesion. With respect to the first chapter, I would say caseous necrosis. Right? That will be the right answer for me here. You're absolutely right. The diagnosis TB. First again, the clues or the data points, however you want to write, or history. If you want to write history, you write a history. There is a low-grade fever. Just try the same thing. There's no error here. You are starting from the question plus evening rise of temperature, weight loss. Unfortunately, everything in this question is relevant for me, and chronic cough. The chronicity is also important for me, right? All points to only one. Clinically also, I am suspecting TB only. Clinical diagnosis is TB. In addition to that, this patient also has X-ray. There's an evidence of X-ray. In X-ray, you have cavity lesions. So most likely it's a confirmed case of tuberculosis. Right? I won't use this example. I'll use some other example there. That's all right. So what I see in microscopy is, in microscopy, I'll be seeing two important findings here. The first finding for me is granuloma. And obviously, it could be caseating or non-caseating or caseous necrosis, right? Okay, that's what I'm going to see in microscopy. How granuloma is formed, why granuloma is formed, you know that we may be looking that in the inflammation chapter a bit in more detail, right? So this is how I'm going to write the reason, what happens, why my diagnosis that. Once it's that sorted, then everything can go. Rather than just write, see, because what is the diagnosis carries 2 or 3 marks. Just writing TB versus how did I come to TB conclusion? You must have thought about this, put it in paper. We cannot read minds, right? We can read the paper. As I put in mind, that's much more comfortable, right? Next question. Come on, everyone online, I want you guys to comment. What do you guys think? Again, it's a simple question. 45-year-old long-standing history of GERD. That's the first clue for me. Endoscopy of the distal esophagus. Second clue for me. Actually, this is not how it should be, but it's fine. Stratified becoming goblet cell is direct, because endoscopy you must have seen the red velvety esophagus, right? So describe the cellular adaptation involved and discuss its clinical implications, right? There are two questions here. Diagnosis, you know how to come to the clues. By this time, I'm sure you will easily write the clues. The data points and the diagnosis here clues are your long-standing GERD, distal esophagus, there's a problem, and there's a classical definition given that squamous is become with goblet cells. That's enough for me to call it Barrett's esophagus, right? Diagnosed, sorted. Can anyone tell me what are the clinical implications of Barrett's esophagus? Clinical implication of Barrett's esophagus. One long-term problem is definitely there's an increased risk of adenocarcinoma. That's definitely that. But Barrett's itself is a concern, right? Barrett's can cause very uncomfortable chest pain, right? There'll be an substernal pain, which will be there chronic, and I'll have complications of GERD also. See, GERD is not just limited to your esophagus. That also will be a long-term complication, because when you have GERD, it might go to the larynx. It might cause laryngitis. It might come to the throat. It can cause lots of problem, right? That also will be there. And like Crazy Loser said, I might have a little bit of uncomfort of dysphagia, but most likely when I have dysphagia, there's always a component of cancer formation, because Barrett's might not cause dysphagia, but the moment it becomes cancer, it's a tumor blocking the esophagus, will definitely have difficulty in swallowing, right? There's always a risk of cancer formation, to be specific, risk of adenocarcinoma formation. Okay, that's what's going to happen here. Okay, done? Perfect. Next one. What do you guys think is the answer? What do you guys think is the answer? During embryonic development, the separation of fingers occurs by selective elimination of interdigital cells without inflammation. Describes cell death in what and explains molecular mechanisms. You guys know the answer, right? It's simple. It's simple apoptosis. To be very, very specific, I should write it as physiological apoptosis. There's nothing more data points here. It's embryonic development and no inflammation are the clues for me to say it's apoptosis, right? Can we quickly go through the molecular mechanisms of apoptosis? Since we have this time, we can quickly go through what happens in apoptosis, extrinsic, intrinsic pathway, everything, and then we'll go to the next one. It's simple apoptosis, programmed cell death, everything perfectly right? So we have two things in apoptosis. One, I have the initiator phase of apoptosis. Then I have the execution phase of apoptosis. In the initiator phase, I have two guys. I have an intrinsic pathway or the mitochondrial pathway. Second is an extrinsic pathway or the cell membrane mediated pathway. That's what we have, right? So first we'll go to extrinsic pathway. Extrinsic pathway, see, I'm not talking about physiological. Generally with pathological, viral infection is a trigger. Virus is a stimulus generally for extrinsic pathway. What happens is, whenever I have a cell with a viral infection, this will have FAS ligand kind interaction. Once I have FAS ligand kind interaction, which came from my CD8 T cells or my lymphocytes. Lymphocytes is what will recognize, there's a problem that comes into play, right? So FAS ligand interaction, once it happens, this FAS ligand will activate an intermediate complex called an FADD, fast associated death domain, that will trigger your caspase 8, which is your pro-caspase 8 to an active. Hey guys. Okay. I think it should be visible. It should be audible. If so, let me know, because I think YouTube is troubling us today. If it's audible, visible, let me know. Fine. I look so sad. Okay, fine. So whenever there's a DNA mutation, what happens is, during a DNA mutation, this will increase your sensors of cell stress. The sensors will identify them. That's your BIM, BID, BAD, PUMA, NOXA. Okay. Once this BIM, BID, BAD, PUMA, NOXA is there, it's going to do two things. One, it will destroy BCL2. That's the anti-apoptotic. Fine. Yes, factory. The other one is, it will increase your backs and back. Fine. If YouTube struggles, we are nowhere near to it, right? So backs and back will be increased. So backs and back is nothing but an ion channel, which will move from the mitochondria. If you can draw, if you can write. From the mitochondria, it will move cytochrome C to cytoplasm. This is the most important thing. If you want, you can write the other case also. There are a few more guys also which will come outside, which will stop the inhibitors of apoptosis. Required, right? Not required, don't write, right? This cytochrome C, once it comes, it will bind to your APAF1, apoptosis activating factor, which produces apoptosome. This apoptosome is the one which activates your caspase, procaspase 9 to active caspase 9. There, if you want, write 8 and 10. 10 is in human caspase, 8 is not in human caspase, right? If like not, 8 and 9 is more than enough for me, right? Okay. There are few more things which comes outside. This might not be required, but if you write, it will be great. SMAC and Diablo, which also will be coming outside whenever Baxenbach is there. This will bind with IAPs and it will destroy the inhibitors of apoptosis. When I say IAP, IAP is inhibitors of apoptosis, which is there in the cytoplasm of every cell. Fine. So ultimately what happens? Caspase 8 or caspase 9 or 10 will be activated at the end of intrinsic pathway of apoptosis, right? Once that is getting activated, what's going to happen next is it's going to lead to the execution phase. So in execution phase, I have only one thing, either I need caspase 8 or 9 or 10. This will activate two guys. It will activate endonuclease. As the name says, it will cut a DNA into tiny little parts. Endonuclease. As per the palindromic sequences, it will cut them. It will cut them, right? This results in DNA fragmentation. In other words, I can write it condensation. DNA will definitely condense and the nuclear will definitely condense. Fine. This happens in one side. Other side you have caspase. So caspase 3 and 6. 3 and 6 actually is caspase is a protease, right? So it kind of shrinks the cell. It's a protease, it destroys the cell, it shrinks the cell, right? When both of them happen, ultimately it'll end up in having tiny little bodies which will be split, which are called as apoptotic bodies. This apoptotic bodies will be removed and thrown away by your phagocytosis by a process called as an efferocytosis, which will clear the apoptotic bodies. For clearing, if required, you can write a little bit about phosphatidylserine, you can write about thrombospodin, you can write about complements as well. But this is what happens in the flow of apoptosis. Yes, well-wisher, you will. Okay. If I can do it, I think everyone are bosses of that. They'll definitely do it. Fine. Okay. That's about apoptosis. We read about apoptosis. We read about one important cellular adaptation. We read about one important intracellular calcification and everything. Can we just quickly go through the types of necrosis also? Necrosis, pathogenesis, you know, it's simple. We'll go through that also, no? The pathogens of reversible, irreversible cell injury, there'll be reduced oxygen. Because of reduced oxygen, you had reduced ATP. Because of reduced ATP, there's no sodium potassium ATPase. When sodium potassium ATPase is gone, automatically the cells swell. When the cells swell, by default, there'll be a bleb formation. When the cellular blebs form, that part of the cellular blood is not so permeable. The permeability alters. That makes more and more of calcium entry, intracellular calcium entry, which activates the enzymes, the phospholipase, right? All of them will happen. That will cause the cell death. This is a template mechanism, and there'll be a little bit modification for each of the type of necrosis, right? 5 important types of necrosis. The first guy is coagulated necrosis, which is the most common one. The mechanism is protein denaturation. Please do remember that's the important mechanism of coagulated necrosis, not only the important mechanism. Liquefactive, it's not the common, it's seen in the brain, right? It can be seen in brain infarct. The mechanism of action is enzyme activation. Fine, right? In solid organ infarct, I see them and you have the maintained architecture and the ghost cells are seen. That's important from microscopic point of view. I can see the architecture. Still, I can say it's a kidney, it's a heart, it's liver. I will be able to say because the architecture will be maintained, but the cell will not be alive, right? Then the abscess cavity. So for liquefied necrosis, wet gangrene, abscess cavity, if you want right here, just to make you happy, dry gangrene. Dry gangrene is nothing but infarct of a solid organ. It's already done there, but if you want write dry gangrene also, right? Abscess cavity will be there, wet gangrene, any supra infection, acute pancreatitis, right? That also to be very, very clear. In acute pancreatitis, there is an enzyme activation, so you'll have liquefactor necrosis only. Surrounding the pancreas, you'll have fat necrosis, because pancreas is not made of fat, cannot have fat necrosis, as simple as it, right? Caseous, only one guy, tuberculosis. You can add on to this your histoplasmosis, coccidiomycosis, your pure neurotic leprosy, that also will have liquefactive necrosis. Sorry, caseous necrosis. Caseous is a modified form of coagulative necrosis because of the organism. More amount of reactive species, more amount of macrophage involvement, the necrosis little bit differs. That's all. Fine. Then fibrinoid. Oid is like, so anything in the vessel, any vasculitis, I'll have fibrinoid. Right? SL is a vasculitis, I'll have fibrinoid. Malignant hypertension. Hypertension involves the blood vessels, I'll have fibrinoid. The biggest vessel in my body is heart. In that we have something called an Ashoff body. In Ashoff body, which is a finding of rheumatic heart disease, here also I'll have fibrinoid necrosis. All these are classical findings of fibrinoid necrosis, right? Great, Mohit. Amylase is getting activated. Not just amylase, lipase, proteases, every exocrine pancreatic enzymes will be activated. Amylase is what I use for diagnose, right? That's fibrinoid necrosis. Okay. If you want extra points, fibrinoid necrosis is also PAS positive. Not required, but if you want more marks, write this as well, right? Fat. Fat necrosis, which have, this is the most important thing in fat necrosis, will happen only in structures rich in fat. Pancreas does not have fat. Pancreas is acini, right? So fat necrosis, I have two things. I have traumatic fat necrosis. Trauma can cause it. The breast parenchyma can cause traumatic fat necrosis. In this part, injection in the gluteal region, injection can cause traumatic fat necrosis, right? At the same time, enzymatic. In enzymatic fat necrosis, this happens in omentum, yes, absolutely, because omentum is fat, and also happens in the peripancreatic fat, not in the pancreas. It can happen in the fat surrounding the pancreas, but never in the pancreas, because fat necrosis can happen only in fat. Please don't write acute pancreatitis. Let any book say it is seen, but not seen, because pancreas has acini. Surrounding pancreas I have fat, in that I'll have it, but not in the substance of pancreas. Fine. Okay. And obviously you know the answer. Once it's there, automatically the fatty acids plus calcium will deposit and has a chalky white thing called as saponification. That also can come as a reasoning out why question. Okay. Soap formation, saponification, which is nothing but calcific salts. Okay. Done. That's kind of trying to cover most of the things with respect to the first chapter. We saw about cell injury, necrosis, apoptosis, different types of necrosis. One cell adaptation, which is important. Hypertrophy also we slightly brushed when we saw the clinical case scenario. Metaplasia we read in detail, right? We also saw one important intracellular accumulation. Rest everything is not worthwhile for a short notes. For your practicals, yes, fatty change is important. Otherwise, short notes, I don't think they might ask a fatty change. And also we saw quite a good reasoning why questions, fine. Any other change you want, put in the group. Because ultimately, I want to, anyway, I'm going to spend time creating the lecture, right? So tell me what you guys want. These are the inputs from what I got to cover more clinical scenarios, to cover reasoning out why. So that will definitely cover. Rest of it also will slowly cover, try to cover as well, fine? Okay. Thank you guys. If you are not a part of the group, ping me here. I'll add you as a part of the group. Let's learn more together, fine? Thanks a lot for your time. You will have a class waiting for you at 6:30, so I'm leaving it to you a little bit early. If you're a part of the Share batch, go and attend that as well, right? All the best for internals. Don't worry about an exam. Exam is a passing cloud. You will do much, much better in future. Fine. All the